The webinar.
Good. Welcome to our webinar today. We are hosting a great webinar on the topic of how to achieve excellence in brain MR image acquisition. This webinar is brought to you by Cerebro. My name is Stefan Braunewell. I am a strategy and innovation advisor with 15 years of background in image computing and radiology AI. And today we have a panel of great speakers that I will introduce one by one in more detail after the initial statements. So first up is Lawrence Tannenbaum, MD FACR, who will deliver a keynote speech to get the discussion going. Then we have Sylvie Destian, MD, James Hillis, MBBS, DeepFil, and Michelle Nemery, MD. And we have this setup from very diverse backgrounds that is very much certain to drive an interesting discussion with great insights and probably also some controversial statements. I'm very much looking towards our panel today on how to achieve excellence in brain MR image acquisition. So first up is Lawrence Ann Tannenbaum from the VP and CTO of RadNet. Dr. Tannenbaum is currently Vice President and Chief Technology Officer at RadNet, the largest provider of outpatient imaging services in the US. At Icahn School of Medicine at Mount Sinai in New York, he attended in neuroradiology and served as an associate professor of radiology and director of MRI, CT, and outpatient advanced imaging development since 2008. He has authored over 100 scholarly and peer-reviewed articles, which have been cited over 1,000 times, chairs educational and academic meetings, and has delivered close to 2,000 invited lectures around the world. Larry, we're glad to have you as our keynote speaker today. We're very much looking forward to your talk.
All right, I'll take it from here. I'm going to do the share screen thing. You need to release the screen.
Yeah.
Release the hounds for me if you wouldn't mind. There we go. Now I can do it. And I would be here, share that, do that. And I think we're okay, right? You guys are in my way. I'm going to get rid of your nodding heads.
You're good.
All right, there we go. All right.
Perfect. Yes.
All right, great. So I've got a few minutes to open this program, a robust assembly of speakers to talk about some of the technology that we can use to overcome some of the imaging challenges in the enterprise. And the question is, there's lots of opportunity, everywhere you look. The question is, can AI and related technology positively impact the imaging process, having a positive impact on patient experience, support and guide our technologists to produce better exams the first time out, reduce the burden on our radiologists, the things that just sort of suck our spirit during the course of a day. And overall, for the enterprise, increase the loyalty of our radiologists, our technologists, and our staff, and end up with better retention by creating a better environment. When you look at the imaging enterprise, everything from the patient through the referring doctor, the technologist, all the way through the modality, before the exams get to us, there's opportunities everywhere. And frankly, failed opportunities everywhere. We have very limited utilization management. So the doctor will order an exam. It may not be the best exam. Once it gets there, the technologist may not have all the appropriate information they need to choose the best protocol. Once they have the information, they may or may not execute the exam perfectly. Image quality can be variable and can lead to patients being called back. And as a radiologist, there's a few things more frustrating than going through a day, opening a case, setting up the images and realizing something is missing and having to start all over again. And once it gets to the radiologist, AI has impact on reducing perceptual errors, but it can also have an impact on how we code exams to get the optimal reimbursement. And it can also have an impact on peer review, because the way we do peer review traditionally is done in an analog, inconsistent, and unsatisfactory way. And all of these are opportunities for AI and related technologies. So When it comes to performing exams like CT and OMR, the exams, in the place where I live for the most part, we can look at ways that we can use technology to get closer to that first time right ideal. And, one of the tools that we see on the horizon are tools that really lean on natural language processing and natural language understanding to assist in picking protocols based on the patient's history. As you know, large language models have the ability to read the medical record and have already shown potential at reading the record, figuring out the indication, and choosing protocols at least as well as humans can do. And frankly, sometimes even better. And, our doctors are always busy. Our staff is really a little overwhelmed. And anytime we can outsource some of this to a computer, which will have fairly consistent performance, if not perfect, it's going to help us. It will almost certainly lead to having exams that are more pertinent to the patient's history, delivering more value. And in the end, we want to reduce the number of callbacks, of course. There are other tools like deep learning-driven autonomous scanning. This tool is now ubiquitously available from all the vendors using deep learning to get the ideal angles so that when we do surveillance exams, we get almost the same picture every time. But it's also been shown to do things like streamline the exam experience. This is data from one of our institutions. As you know, I work with one of the largest outpatient imaging organizations in the U.S., do close to 10 million exams per year. Anything that can affect the imaging process really helps. And in this case, I had the same scanners, 2 blocks apart, same radiologists, same protocols. The only difference here was one had autonomous scanning and one didn't. And you can see from the comparison of the 2 studies on this lumbar spine, we're able to get patients off the table more efficiently using these tools when there are fewer clicks and fewer adjustments that need to be made. The manufacturers all realize that with a dearth of experienced technologists, more and more inexperienced technologists at the scanner, that they need to make their user interfaces more error-proof. And here are some of the works in progress that the vendors are working on. This is an example of a GE works in progress, simplifying some of the more complex exams. I know that when I program the GE scanners, particularly with the traditional design, it gives me a very, very bad headache trying to remember how to think my way around the user interface. It's nice to see it simplified. Other complaints that you hear from other folks is there's too many parameters that can be adjusted or misadjusted. As you can see, they're all working, the vendors are all working towards simplification, reducing the number of adjustable parameters so that we can get our exams done more consistently. Siemens has taken this one step further. On some of their devices, they already have this user interface where essentially you pick the exam, you do nothing but sit back and watch the images come out. And of course, in a certain environment when we're doing a lot of bread and butter work and we have a dearth of skilled, highly skilled folks to work our equipment, this really does help. All right. Another piece that I think you'll hear a lot more about even today is in looking at inline quality assurance. So rather than looking at the exam afterwards and say we should have done better, we can do this while the exam is going on. And the problem is if you rely on our technologists to make these decisions whether an exam is good or not, they have no objective measures of what's acceptable and what's adequate quality. They just don't have it. So what happens is we get a lot of scans repeated when it's really unnecessary, sometimes our longest exams, and this leads to a longer time on the table for patients and certainly reduced efficiency. And from the operations point of view, a lot less predictability. If we think an exam is going to take 13 minutes, but with any given technologist, it always takes 17 minutes. This throws off our entire plan, and of course, makes us build in more dead time to stay on schedule. On the other hand, many series that the radiologists wish would be repeated aren't repeated because, again, there is no standard criteria, and it's a choice between getting the exam done or protecting yourself against criticism, which comes later. But in the end, if we don't get a great exam, we end up with patient recalls and a diminished exam value. Again, the vendors are all working on this. This is an example of a GE tool that will be integrated into the devices where it actually looks at the examination, and depending on your setting, it will tell you, you can actually set it to reject mild or just moderate motion or the like, but this is inline. It will tell you whether you need to repeat something, hopefully eventually before it gets repeated, but before it gets finished, at least in the near future, when it's done, it will give you that score. Other vendors like Settle Medical are working in the DICOM space, doing fundamentally the same thing, looking at the quality, looking at the SNR, looking for motion, but also doing things like looking for completeness, looking for appropriate positioning. And when reformats are important, as we move to 3D, more and more reformats are important. It will get those and ensure those are in the ideal format, as well as actually working at some of the DICOM signatures and making, cleaning those up to make your hanging protocols work, perhaps. Now, the part that we really are most interested in today is this issue of on-device decision support. And imagine a world where something like the Cerebro Apollo setup can actually look at your scans and identify critical findings during the examination, allowing the technologist to either summon someone's assistance or even guide them to doing the appropriate protocol. This is a big difference from where we are today, where we find things afterwards. Now, a lot of times in many settings, people rely upon their technologists to detect urgent findings. And this is a very difficult thing to do, particularly as we start to hire younger and younger people, and could lead to more and more interruptions. It's really nice to have this on-device, inline AI looking for some of the urgent findings we need to do. Once it identifies those findings, again, it can suggest the appropriate protocol, but at the very least, it's going to push you to the top of the list so that you will know to read those exams first. And there are a few circumstances where this type of triage is important and must be on the device. I think this is a circumstance where it could make an enormous difference. Now, in some settings, you can actually use this capability to do a different approach, as opposed to doing a shotgun brain MRI with all of the different aspects that we do in every individual case. In some settings, it may be best to do the basic screening sequences. And if the AI says you're done, you can actually take advantage of the ability to say there's nothing here to find, to open that scanner capacity to another patient. Or if you do see something, you can actually take a personalized or disease-based imaging scheme to go further. So this is really an exciting development that is now available through the Apollo setup. As a matter of fact, it's already being integrated into the Siemens user interface as a tool, and hopefully it will end up on all the user interfaces, because frankly, this is a capability that I think is highly valuable in the actual inline setting. So, using these dedicated workflow solutions, again, you can see the opportunity to actually select certain scans, prioritize review, and in some cases, in some settings, reduce unnecessary scanning to get the patients off the table faster. The last piece here in the last couple of minutes is talking about another thing that we can do, and another tack that we can take when we don't have the personnel to run our machines, and that is remote operations and support, which is a big deal for us. It's a big deal for everyone, frankly, because the things that I mentioned earlier, with a scarcity of skilled folks and a diluted talent pool, the situation is so bad around the world that scanners can sit idle with no one to run them. It is really a remarkable advance that we now can have people working remotely and running a number of scanners simultaneously, either giving educational support or giving actually running the scanners with a safety trained ancillary personnel, like an assistant sitting at the console watching the actual patients. Here you can see an example of an assist setup where a senior technologist is training a junior. And she's now allowed access, and they can actually review the scans together. And you can see certainly how this would help with education and in difficult circumstances like cardiac MR. And, rather than diluting the actual quality of the interface by moving the technologies off site, by leveraging the strengths of our best technologists and distributing their expertise both for training as well as running the difficult examinations, we have found that we actually produce the best quality work with the lowest error rates, as you can see here with the orange line, when we operate remotely. So we talked about a lot of different things in these last few minutes, things that we can do to leverage technology to improve our performance and get closer to that first time right ideal. And I look forward to hearing from the rest of our panelists for the remainder of this program. Thank you.
Thank you, Larry. And I'll shift to gallery view.
Okay. Thank you very much, Larry. This was really a great overview of so many different approaches and current opportunities already that we are seeing in the space. What a great start for this webinar today, and I see a lot of nodding faces already. So before we go into the actual panel discussion, I would like to welcome the audience again. Great that so many people are interested in this topic, and I would like to point you to your possibility to participate in this discussion. We have in the bottom of your Zoom window, we have the capability to ask questions. There is a Q&A feature. Please feel free to ask anything that you're interested in to the panelists directly or to the round in total. So we will now have each of the additional panelists basically virtually coming on stage with me giving a short introduction of each of them and them giving a background and intro statement. What are they particularly passionate about? What is it that you really believe makes the difference for excellence in MRI acquisition? So first up is Professor Sylvie Destian, MD. She has held academic positions at USC, St. Luke's Roosevelt, and St. Vincent's Hospital, Manhattan. Most recently, she was professor of diagnostic radiology and pathology and section head of diagnostic neuroradiology at SUNY Upstate Medical University. She's now professor emeritus of diagnostic radiology and pathology at SUNY Upstate. Sylvie, please tell us about your personal background and in the topic of MRI, and what does excellence mean to you? Sorry, you're still muted.
Thank you for the kind introduction and the invitation to participate on this project. When I started out at USC, that's where I met Dr. Tannenbaum, and we've remained in contact ever since. He's one of my star fellows. My interest in AI stems from the fact that even when I was at USC, I thought most places have a shotgun approach to MRI, and we did too many sequences. People at USC learned that they could get their spine studies faster if they said, we need to rule out cord compression. So we devised a protocol where we only did sagittal T2s of the entire spine. And if there was cord compression, we did a full study. And if there wasn't, they went back in the queue. When I got to SUNY Upstate in 2011, I was horrified that every child under 2 was given contrast for an MRI. The most common indication being seizure. And the American College of Radiology doesn't even recognize MRI as a reasonable study for seizure in that age group. So what I did was I spoke to one of the pediatricians and suggested that they do not order contrast anymore in 1 or 2 of these children who'd had negative studies. And she asked me to speak to the Pediatric Society, which I did. I chose seizure as the topic, and because it was the most common indication for an MRI with contrast in children under 2. And I showed them 20 diagnoses in all disease categories I showed them different diseases in all of the categories that could cause seizure, and showed them that the diagnosis could be made on a non-contrast study with minimum sequences. The following year, the contrast requests in this age group dropped by 90% and remained low until the FDA approved contrast in children under 2. I still strongly object to this. I don't think children under 2 have mature kidneys. We know that gadolinium is deposited in tissues, and we have no idea what the long-term effects of contrast in this age group will be on their kidney status. I still feel strongly that we over-image people. I think when younger radiologists joined our group, they wanted more and more sequences. And as Dr. Tannenbaum has said, we have fewer radiologists, we have fewer technologists, and we need to get the diagnoses with the least amount of sequences. And that's what interests me about Cerebro, because I think it can be done. And I just think we need to inform more people about it. Thank you.
Thank you, Sylvia. I think this is already a very, very nice point to pick up on later. So appropriate use of contrast media and over imaging. I think this is something that James will also directly connect to, I can imagine. If efficiency and effectiveness is your topic, as you told me. So let me introduce James Hillis. Dr. James Hillis, who completed medical school at the University of Melbourne and a doctorate at the University of Oxford, is an attending neurologist at Massachusetts General Hospital and instructor in neurology at Harvard Medical School. He's also the director of clinical operations in the digital CRO at Mass General Brigham, where he leads investigations of devices for regulatory approval. So, James, you say you're on a personal mission for efficiency and effectiveness in healthcare. How does that tie in with our topic today?
Thank you very much for the warm introduction, Stefan, and thank you to Cerebro as well for the invitation to be part of this webinar. I agree entirely with the points that Sylvie brought up, and for that matter, the points that Larry brought up as well, with regards to sort of the potential benefits that AI can offer healthcare. And Stefan, as you were indicating, one of the big areas for me, one of the drivers for me is thinking about how can we actually improve health outcomes through the use of AI? And ultimately, a lot of that comes back to effectiveness and efficiency of how we provide healthcare. And to build on Sylvie's point with regards to the use of gadolinium contrast, it's something that I'll say as a neurologist, I have plenty of patients who come to see me who have either already had an MRI that's acquired that has had contrast performed with it, where I'm saying, okay, what was the value out of that contrast? And also plenty of patients who will actually see me in clinic and actually just say, well, hang on, I had the MRI, but it wasn't with contrast. Is there something that's missing? And I think for a lot of people out there, there's this perspective and this view that more means more, and as a result, if you're not actually doing something, you're missing out on performing something. And so I think this is where Cerebro offers a huge amount, in particular through the smart protocol side of things, where the truth is there are only a few diagnoses where you really need to perform contrast to actually figure out that you're missing something that you wouldn't capture otherwise with other sequences that you'll routinely perform. And so from my perspective, it's something where it is super, super important for images to be acquired with the appropriate sequences and only the appropriate sequences for those patients. And if there's something that's discovered that requires the contrast, then it's something where that contrast can be then provided. And that's something where if you've actually got AI that's working at the same time as the scanner is acquiring these images at the actual scanner console, then it allows you to have that add-on type approach where you can acquire the contrast only for the patients who really need it. Mm-hmm. I'll also say at a broader level, in thinking about what I'm looking forward to seeing at RSNA, I think one of the key areas where radiology AI is heading at the moment is very much around the thoughts of more holistic end-to-end type solutions. And so with Larry having displayed the flowchart of these are the different parts of the image acquisition and then the image interpretation process, it's something where I'm really looking forward to seeing more thinking about, okay, how do we actually go from the very start of somebody has symptoms and an order is placed through to the actual final acquisition and interpretation of that imaging. And I'm looking forward to seeing how people approach this in more of a holistic, integrated, streamlined type of way. The second thing that I'm really looking forward to at RSNA as well is seeing how generative AI with large language models will be built into a lot of this process. So thank you very much again for having me, and Stefan, back to you.
Great. Thank you, James. I think very interesting points that you bring up that we will pick up on in the discussion. But let me bring in Michel Nemery into this discussion, and then we open the round for our panel. So, Michel, with over 14 years of experience as the former chair of the Department of Radiology at Herlev and Gentofte University Hospital in Copenhagen, Denmark, Dr. Michel Nemery brings extensive experience in healthcare innovation, digital transformation, and AI. He is the founder of the Innovation Unit and the Radiological AI Test Center. He has recently joined Cerebro as clinical advisor. Michel, you have seen imaging innovation from different stakeholder perspectives. Please share your insights.
Thank you. Thank you. Yeah, I actually will pick it up where James left it off, because James, you expressed that you were curious to hear about more holistic approaches, and listening to Larry and listening to Sylvie, I'm sort of in the mirror. I'm seeing someone who has a definitely more holistic and specialist approach to creating value for patients faster. So I'm actually a very patient radiologist, and I used to be a clinical neuroradiologist, but for the past 16 years, I've been, let's say, a leader of radiologists. And what I think is my passion is actually accelerating how we develop, design a technology that will enable, with a little bit of, let's say, creativity and thinking outside the box, us to modify our, let's say, our workflows, the way we are used to doing things, to allow for technology to take over tasks as the technology matures. So that sounds maybe a little abstract. So to put it in context, speaking specifically about AI in radiology, it will not replace complete radiologists anytime soon. But if we take a holistic approach, and we can root this in Cerebro's technology, if we approach the neurology department and say, what action would you be prepared to take if we promised we could do an MRI of the brain within 30 minutes every time you have a patient at the emergency department with acutely onset neurological symptoms? How would that provide value at the Department of Neurology? And what if after 4 o'clock in the afternoon until next morning, and the whole weekend, the results of the scan would be delivered by a technology like Apollo, like a smart alert saying, you need to check the scan. We think there's ischemia, or we think there's a tumor. How would you be able to change your workflows? And I've worked in my previous job also with Cerebro, creating this, I call it like a target image. How wonderful would the world be if, and now we know the kind of the answer, if up to 70 or maybe even more of these patients were able to leave the hospital directly from the emergency department, not requiring any bedtime or to be kept in the hospital for, let's say, more than 4 or 5 hours. And this is including people or patients presenting with transient cerebral ischemia. And waiting for technology to mature, at my hospital at Herlev Gentofte, we actually got the money to fund, let's say, a pilot. It's actually become a regular operations now for the past 2 years, that we were able to staff with neuroradiologists on the weekend, which we didn't have before, and until 8:30 at night on weekdays. And that increased the percentage of patients from 40% to 70% that the neurologist department were able to discharge directly from the emergency department. And that's the kind of holistic approach that I think I would like to see more and faster in deploying AI into the clinical space. Yeah, so I think I'll leave it there.
Great, thank you very much, Michel. So we have a lot of things to talk about. So took a lot of notes, and we'll go through them one by one. First of all, let's start from volume, from our outlook. How do you, Larry, see the immediate, let's say, next years of imaging volumes of brain MRI? In particular, now, just last week, there was a publication that specialized MRI is actually more cost-effective than alternatives in the emergency departments for patients presenting with dizziness. So we get these kind of news. We also get the overall expectation that more and more use cases will be actually appropriate to be imaged by MRI. How do you see, what's your expectation for the next couple of years? I'm sorry, you're muted, Larry.
I don't think it's any great insight of my own to say that the volume of advanced imaging examinations will continue to rise. I don't think there's any question about that. The evidence you cite is certainly powerful, but I think the actual numbers just illustrate that in virtually every setting. So that situation will not change. Our radiologists are being asked to read more and more exams per day. With all of the mass resignations and the migrations that occurred with the pandemic, the situation, the mismatch between the cases that need to be read and the folks available to read them has only gotten worse, and it's a challenge. Things like one of the biggest developments that I think will affect neuroradiology is the situation around disease-modifying therapies in Alzheimer's disease. Folks are going to be treated with drugs that are effectively clear the amyloid and improve cognitive performance, but these drugs have complications associated with them, and these complications need to be monitored for. And patients on these therapies, as many as 1.5 million Americans, will be on these therapies, being eligible and having the early stages of dementia. These patients may see anywhere between 5 to 10 MR exams per year. Mm-hmm. So aside from the trends you're already seeing, this is just on the horizon. So again, this will also create a mismatch between the capacity of MR scanners and the demand from the clinical sphere. So that's another opportunity, I think, both that I think perhaps companies like Cerebro could address by streamlining the MR experience. Now, we have a lot of impact with things like deep learning reconstruction, which makes the exam faster. But I think these other pressures just would add a premium to something that would essentially tailor the examination. Getting it right the first time, really important, but also perhaps getting off the table a little bit faster.
Right. Anything to add from the other panelists on this point?
I have a question for Larry.
Mm-hmm.
How do you deal with exams where an insurance company has approved a certain type of exam, let's say a contrast exam, where it's not necessary, and you're bound to do it? And this is, to me, very frustrating.
Well, I'm listening to. I was listening to both of you folks that talked about contrast agents, and I am not very much afraid of contrast agents. I think choosing the right agent, you can focus on the value that the contrast brings and not be fearful of the complications associated with the contrast. On the other hand, like you and like all of us, I don't feel that contrast agents should be given if there isn't a good a priori sense of the value of the contrast agent. So getting back to your question, thank you for the opportunity to proselytize there. Getting back to your question, it's a very frustrating circumstance. And in many circumstances, we really can't make that change without an enormous amount of administrative burden. It's tough to actually do that. And, that is an area where one hoped that we would be better. And over the last few years, particularly with the legitimate concerns about particularly the linear contrast agents in certain populations, but we haven't made much headway. It's very frustrating for us to change those orders. It forces us to go back and call call the referring physicians in many circumstances, and that again pulls someone out of their offices. It's it's a very unsatisfying circumstance. I was hoping if you brought it up, Sylvie, that you had an answer for all of us. Do you have one?
No, I don't, because you're right. You have to call the clinician. They don't want to deal with it. They have to have staff to call the insurance companies. And I think in the US, it's even worse because Medicare determines certain things. I don't know if you've had this problem, but the NASA criteria was written for CT, but you can't get paid for an MRA unless you say that all measurements are per NASA criteria. Has nothing to do with MRI. But now we put that, excuse me, as part of our standard technique, just so that we don't have to deal with non-payment.
Yeah, it's an interesting circumstance because the technology we heard about today, which would suggest you give contrast on the fly, is diminished by by payers. Certainly in certain circumstances, we have the freedom to use our judgment. And I would say our judgment can be AI supported and fueled. So I don't have a problem with that. But in many of the patients that are on our scanners are in that older population where we have that freedom. But I do think that there are headwinds with some of the third-party payers, and that is, again, I don't think it contributes much to the welfare of our patients and just adds an administrative burden.
Good. Coming back to the question of, given rising volumes, given lack of technologists, where does AI come to the rescue? What are the immediate expectations that you have, or even ideally direct experiences where you see that AI is actually alleviating that situation? Your current experiences or future expectations, let's say short-term future. Who wants to start on this? Maybe James, would you like to comment on your previous experience?
Definitely happy to comment. And I think for me, one of the big use cases for AI is even just going back and saying normal versus abnormal. And especially as the number of radiology studies performed continues to increase at such a fast rate, but the number of radiologists does not necessarily increase. It's something where the ability to differentiate between normal and abnormal will make a big difference to interpretation and clinical care. It may even get to the stage, and I'll emphasize that it's not at this stage at the moment, where sort of the studies that are deemed by AI to be normal don't even need to be interpreted necessarily by a radiologist, versus those that are abnormal go straight to the radiologist and really allow radiologists to focus on the more complex interpretations of what's going on.
Mm-hmm. Further examples, other thoughts? Yeah, Michelle?
Yeah, I agree totally with James. I think the volumes will keep going up, and the number of radiologists, and it will not, and their brains will not grow any further. They'll look silly anyway. So actually, we should take a look at what is it actually that we deliver. What's a report? Can you imagine, for instance, having patients in an outpatient clinic who are being diagnosed for a chronic headache? Could they have an MRI done by, let's say, remote support, have Apollo do the screening, and the report could be the tumor load of this brain is 0. I mean, why is that not what the neurologist is looking for? So if this is a special case, or this patient has a twin with a syndrome or something, you can always approach a specialist. But if all you need to do is rule out a brain tumor, because then you can go on with your treatment plan, why is a report not an automated, let's say, measurement? Not a report, but a measurement. Tumor load is 0. What do you think?
Any responses on that?
Well, certainly AI can certainly play a role in screening some of our examinations. I'm not a fan of de minimis reduction of what MR can do for us and CT can do for us, or any of the diagnostic modalities can do for us in these circumstances. But I do think that AI can impact us in a number of ways that I laid out beforehand, including improving the performance of human radiologists in some circumstances in terms of pattern detection and lesion identification. I think, again, these are very powerful tools, CT and MR, the most powerful tools, and frankly, in the history of medicine, certainly while I was alive. I've been alive. As you can probably tell, it's been quite a while. And I don't really want to diminish what they can do in terms of detecting disease and characterizing disease and the like. I do think, however, that, as you heard in my presentation, that doing anything you can to make that process more efficient, less painful for patients. Patients really do not like it in the MR scanner. A very significant percentage of patients really find it to be fairly close to terrifying. The ability to get patients out of the machine, get the answer right the first time, increase capacity on those machines by making the exam more concise, more consistent, and frankly, more diagnostic, I think will help. I am perfectly happy doing MR the way we do it with these enhancements that make it less painful and perhaps more personalized and disease-directed. On the other hand, I think to imagine an AI saying, I don't see what you're looking for, and then sending you home makes me just a little bit nervous.
Sylvie, what is your take on this? Also,
I agree with Larry on his last point. It's one thing to have an AI program pop up with a case and say, read this next, because they do see something. But I would be a little bit leery of a program that would stop an MRI and say, we don't see this diagnosis.
Mm-hmm. So going to the broader sense of AI use, are there specific examples where you, Sylvie, see the role where you have experienced AI, even in a little bit of a different setting, where you see the potential for this to also come over to MRI to actually make a difference?
Absolutely. I think alerting the radiologist to a potential abnormality is very important because, as someone mentioned before, we no longer can rely on techs to do that. The more experienced techs have retired. When I was first starting out, we used to say that techs protected the radiologist from landmines. And in my experience, they were great, but fewer techs look at the images the way techs used to. They don't have the time and they don't have the experience. I think the appeal of Cerebrio is that we don't need all the sequences that we do. And Larry's totally correct in that patients spend way too much time in the scanner. So I think that's where the value comes of tailoring the exam to what is needed, not necessarily saying, okay, it's normal, but alerting the radiologist to when it is abnormal and also shortening the exam.
Okay, very, very good point. So Larry, with your experience, also your view on many different imaging centers all over the States that probably run differently, all have their own culture, their own change management procedures. How do you see the challenges of adoption of technologies like this in the practical workflow?
Well, it's an interesting question. We are a large organization, but we have essentially an organizational ethos that pervades everywhere. While we have a number of different physician groups around the country that that have their own individual style, our focus on patient-centered care, on efficient imaging management, maximizing what our technology can do for our patients, and frankly, not overstudying patients pervades throughout. Frankly, any tool that impacts the enterprise in the way that we described today, would be easy to adopt, at least in terms of spirit. The challenge with adopting any AI tool, however, is the American healthcare system is set up in a way that it is difficult to spend on something without having dedicated reimbursement. So it becomes a very difficult circumstance to figure out when we pay and who we pay and who pays, right? If the tool makes the radiologist more efficient, this case could easily do that. Is it the radiologist that would then pay? So then they could theoretically read more exams per day, which might benefit them in some way if they're on an RVU setup circumstance. Or is it the administration that is struggling with turnover times that are starting to extend to multiple days in the real world? Is it the administration that would pay? But in both cases, people aren't all that anxious to be the one to step up to pay when there isn't dedicated reimbursement. So the numbers have to make sense. You can see how they clearly make sense. And in certain circumstances, we do that. We pay for things like deep learning reconstruction without having a direct payment back because it allows us to be more appealing to patients and get more scans done per hour, right? Okay. These circumstances, we can certainly see the value of these tools, but without dedicated reimbursement or something sent back to us for our increased costs so that we can do our job better, it's a difficult sell. I do think that eventually the sell will be made because it just makes so much sense on the surface. But this is kind of where we're stuck. And I think a lot of organizations are stuck in how do we pay for quality measures? Okay, where is the input cash to buy these tools, these AI-driven tools, and other tools that will allow us to be more efficient and do more per hour? It's a tough circumstance. I'd be interested if any of the other panelists that sound like they're from a variety of different backgrounds might want to chime in on this particular issue.
So, would like to take this one then, James.
I'm happy to chime in a little bit. I think one of the key things that I've seen is really AI needs to make sure that it's fitting into existing processes and providing value add there. And I think this comes back a little bit with what Larry's saying from the reimbursement perspective, but it also comes back to the actual end user perspective of if all of a sudden you're needing to click many more times to actually use the AI, it's something that you're not necessarily going to click out of your usual workflow to go ahead and use it. And I'll say from a neurologist's perspective, one of the first AI apps that I was introduced to over the past sort of 5 or so years is the Viz AI tool where beyond just interpreting CT scans for a large vessel occlusion, their app also provides a very efficient way of communicating amongst a stroke team such that you can make sure that everybody's on the same page with regards to a patient and the different factors, including about their care, such as last seen well time and NIH stroke scale. And I'll say for me, wearing my AI hat, I'm sort of saying, okay, how well does their large vessel occlusion model detect large vessel occlusions? And is it providing value add from that perspective? But I'll say a lot of my colleagues have really emphasized just how much they value even just the app alone with the ability to communicate with everybody else. And so I'll say in terms of the adoption of that model, I think that a lot of it has also been generated just by the fact that it's actually streamlined a separate process that's actually independent of what's happening with the AI side of things. Of course, there is then the benefit that it's helping to detect large vessel occlusions earlier as well. And so it provides that value too. But it's very much the fact that you've got these abilities to drive forward the innovation in multiple ways.
Very good. Great points. So Sylvie, thinking of the MRI workflow really, and thinking of streamlining procedures, how do you see AI-based support in image acquisition being adopted, coming into the actual workflow? Are technologists able to take this? Will this, in which form will this affect the radiologist's work? So if you think of, for example,
I think
the sequence optimization, right?
I think the biggest hump would be to get hospitals to adopt this. And the push would be that you can do more exams. Most Trauma centers now have software that alerts you to blood on a CT, and all stroke centers generally have rapid software. I think the issue is partly what Larry was saying, getting who pays for it and convincing them that it's worth paying for because they will get more exams done. And right now at SUNY, we had to do every MRI that the ER ordered, regardless of whether it was indicated, because we were told that all exams in the first 24 hours get paid in full, done through the ER. So again, I mean, if you can demonstrate to hospital administrators that it's to their benefit to get the software, they'll do it. But I think that is, that will be the big hump to get over.
So now, thank you very much, Sylvie. We already, Michelle, you have something to add on this?
Yeah, it's very interesting to listen to you guys, and you are all working in the U.S. So what you may not know about Denmark, where I have had my career so far, is that 95–96% of healthcare is public. So listening to how your world and the reality of how you will be able to gain access to this kind of technology will be determined by who pays. That's not the case in this country. If I was still the chairman of my department, I would only have to convince a James, and we would go to the CEO of the hospital and say, look, James says this is worth it. We have numbers to prove that overall between our departments, this makes sense. We can shut down 2 of James's emergency beds in neurology. That's worth a lot of money, and this only costs so much. So that's how we would do it here and have done it in the past. What I will say, which is a little surprising to me, is an idea is gaining traction in this country that department heads are willing to pay. I'm not quite sure how they get the money, but they are willing to pay to have the triage function of what in Apollo is called Smart Alert, to make sure that the scans done on Friday are all checked for critical unsuspected findings, that they can report them way before Monday or Tuesday if they have a backlog. And it seems like in many places, maybe the university hospitals are not in the worst situation here, but more in the periphery and in the rural hospitals, they certainly do have backlogs. And I just saw on LinkedIn today that about 34% of the radiologists that answered the question of, what's your median reporting time, and 34% said above 24 hours. So the short of it is that it seems like there's a willingness to pay to not get that ugly surprise on Monday. And maybe that's, you can, let's say, wrap this in a branding in the US, I don't know, but, it would be good for image, the image of the hospital, to not have those cases. Maybe it's only once or twice a year, but they tend to be very ugly to the patients, and they tend to be very ugly to the team, the care team also.
So before we're taking questions from the audience, Larry, I think you want to add something on this.
Yeah, I would say that taking the payment out of it, and you notice when I described my comments, I threw the American word in front of that. I suspected that there are folks on the call and here on the panel that had different environments. But I would say that the value of these triage tools, whether they're inline or on the PACS, has been proven pretty well, right? In stroke, we can markedly reduce the time to a recanalization, and that has had a huge impact. But the ability to detect urgent findings like pulmonary emboli or fractures or hemorrhage, as you can see, has had enormous relevance in our settings, and you can see the capture rate has been good, even though there hasn't been any dedicated reimbursement. As a matter of fact, in some areas, the hospitals have seen this as actually a money-making opportunity, where if you pick up folks who, say, have incidental PEs and these patients can get treated having an impact on the outcome and also an impact on the hospital bottom line. And my understanding is that there are a lot of hospitals that see this as a significant revenue source that can make a difference. On the other hand, we talked about the full spectrum of the enterprise, and you can even go to the end of the enterprise when reporting comes up, right? There are tools that can actually, what's the word I'm looking for? Synoptic reporting, that can actually take the report and make it palatable to different groups. But, you know, on the financial side, again, looking about institutions, they can also look at patients who have had recommendations for therapy, for follow-up exams, and who haven't come back. There's a revenue source, as well as an improvement to the quality of care, making sure people get their recommendations. There are ways these tools, essentially now based on large language models, that can read your recommendations and determine whether or not they meet the guidelines of the group you're working in. You know, is it a 6-month follow-up? Is it a 6-week follow-up? What does the group agreed upon? And if it's not correct, it can actually correct those. Again, doing the best and most appropriate, most evidence-based care, but in other circumstances, making sure people come back to your institution, to your practice, to your hospital, and bringing those patients back in, again, increasing revenue. These tools are essentially already playing a role in a number of different settings that are only going to mature and become more important to what we can do and will do over the next few years.
Great. Thanks, Larry. So let's take questions from the audience. We already have some, and I invite all the attendees to pose your questions now, that we can just collect them and ask them to the speakers. There's a question specifically to James. As a neurologist, how would you see getting an AI result with suspected findings before the radiologist has had the chance to review the case and provide impressions? Would you take would you be comfortable in treatment planning or prioritization, getting in touch with the patient when leaving the scanner?
It's a great question, and the first thing that actually comes to mind is that it's something that is nuanced, because ultimately it depends on what's taking place for the patient. But I'll say at a big picture level, if the patient has a critical finding that's noted, for example, there's DWI hyperintensity, and you're thinking, okay, this person has an infarct, it's something where you can actually act on that immediately and suggest to that patient that they go straight to the emergency room, which I think is something that I would be comfortable acting upon. And beyond that, I think it actually saves a step in the process to actually get the patient to the ER faster than they would otherwise. I similarly think, and there are a number of devices out there that look at MS disease burden and the T2 flare hyperintensities that you see there. When I'm treating somebody with MS, essentially the critical question for me is there anything new that's taking place on their scan? And so if there's an automated way of actually quantifying the disease burden on the MRI, and I see that that's increased from one scan to the next, it's a similar sort of story where I'd say, yes, I'll say, yes, I would move forward with thinking about changing their treatment. Of course, it would depend on their symptoms as well. The bit that I was going to add in is that I would actually review the images myself first, just to confirm what the model actually suggests is actually what's seen on the study.
So what do the radiologists think about this? There was the recent, I think last year, FDA reminder of the indications of use for triage tools, and in particular, keeping the radiologist in the loop for the actual decision-making and diagnostic process. So how do you feel about shortcutting to neurologists?
Stefan, I don't want to let that comment that Dr. Hillis just mentioned, I think, go by without some echo. I love the idea that our colleagues in neurology are as focused on the value of the examination as possible when it comes to diseases like multiple sclerosis. And since this is an AI-themed presentation, I'd like to point out that there are very, very powerful AI tools that will help us detect new disease, increase lesion burden, active disease where it might escape. It will escape our notice in many cases. This is a very, very big deal. These quantitative tools are going to be increasingly important as we go forward. And I love hearing from our colleagues in neurology that they appreciate the value of that, critical information. Is there something I need to change in the treatment regimen? I see a lot of heads nodding over there. And since I'm talking, I completely forgot the rest of your question, Stefan. So I'll let somebody else answer the rest of it.
So just as a reminder, my question was shortcutting directly to neurologists. How do radiologists feel about this?
Oh, I actually answered that question offline, to tell you the truth. I think it is. I think there is value in, but concern in being able to say this exam is almost certainly normal. Because remember, AI is only certified to comment on what it's trained in, right? And at least in the US, this is a painstaking step-by-step, disease-by-disease process. It isn't the same that way around the world. And frankly, there are some places where there is neither regulation nor radiologists where these tools can help an awful lot. But I think if you could rely upon an AI to say that the study is presumptively normal, that information going to the neurologist is reasonably powerful. On the other hand, if it's going to send a note that says the study is abnormal, that note would go to both radiology and neurology simultaneously. And I think the dilemma asking whether or not they could act on their own, would be comfortable if they've had this information on their own, is artificial, since that information would be provided to both of us simultaneously in a triage type setting. So less uncomfortable with the normals and not really terribly worried about the abnormals because we're both going to get notified.
Okay, any other thoughts? Michel, please.
Yeah, I would just like to add that when we discuss topics like that, we're actually trying to, let's say, feel comfortable in the present, but trying to predict the future at the same time. So I always like to think on a timeline. So your question is, is it okay to, let's say, circumvent or shortcut the radiologist? I think in a matter of time, technology will mature. And in more and more cases, actually, like the one, James, you described with multiple sclerosis, the scan will be a measurement. And let's say the measurement can sometimes, and more increasingly often, it can be very exact. And in the hands of the relevant, the referrer is a specialist here also, not just in neurology. I'm pretty sure, James, you're probably pretty good at looking at MRIs as well. And on a timeline, I think the balance will shift that, we will not, let's say, we cannot work the way we always have, but faster. I don't think that's the ultimate potential of AI in radiology. I think we also need to look at, where do we add value to the patient in that process with the resources that we have. But I don't have infinite compute, and I don't have enough radiologist friends to help all the patients that have a need. So I think it's very important that we realize and that we anchor the discussion on a timeline. And something can happen next year or next month, and something can happen in 5 years. And in 10 years, I bet you, a lot will be different.
Thank you. So here's a different dimension. There's a question from an attendee about reimbursement in adaptive situations. So some CMS servicing providers use short protocols, predominantly without contrast. Would in-process determination of contrast relevance, e.g. suspected tumor, be possible to handle reimbursement-wise? Who would like to take this one? Any thoughts on this? Otherwise, I'll rephrase it.
Go ahead, Sylvia. I was hoping you'd answer this.
Yeah,
Is the question that mid-exam you could change it to contrast?
Yeah, exactly. The question is whether this can be covered by reimbursement. Yeah.
I think it depends on where the patient is imaged. If they're imaged in the hospital, it generally would not be an issue. In an outpatient setting, Larry may be able to address this. It might be an issue.
Larry, what do you think about outpatient setting here?
In the current situation, we are, we commented on that. We're limited in terms of what we can do in terms of the contrast and in the face of reimbursement. So, one hopes that with these tools, with the inherent ability to decide on the fly, you would hope that eventually the payers would adjust around that and accommodate that approach. Because again, it's not in anyone's best interest to make the patient come back, to delay care, to dilute the value of the examination. So, but it has been a situation that we've lived with here for a long time. For the folks that don't have to deal with CMS and the third-party payers in the US, I salute you for being able to do the right thing, and I hope you do. And these tools can really make an enormous difference in terms of all the pain points I mentioned, without that headwind standing in the way of the reimbursement process.
Great. So let's come to our final round. I have one question for all of you, so you have a little bit of time, except the one who gets first. But the rest has a little bit of time to think about it. So my question to you is, well, if it's basically a wish list, and you think of what you could get next, what is your top wish, your top priority for an AI support that would help you achieve excellence in brain MRI acquisition? Anybody brave enough to go first? Otherwise, I will just.
I'll give you an easy one. I'll take the easy answer and let everybody else suffer, with taking the easy answer. And I think this was mentioned beforehand. I don't even want to dream about the tool. Okay. What I will say is I want the tool to be fully integrated into my environment, to add absolutely no headwind to my productivity, to seamlessly improve my performance in terms of doing my job and make my job easier. Seamless, integrated, no headwind to productivity. And then anything you send my way that does anything good, I'm gonna consume like crazy. The ideal tool, while you're imagining that, I'd like you to be fearful of all the dangers as well, right? Of bias, of bad behavior. So in all of these circumstances, there's all kinds of promise and fear that's going on out there. But now that I've given the rest of you guys time to imagine the perfect tool, I'll hand it over to you guys.
Thank you. Very great.
I think one thing that has to be addressed if you have these integrative tools is that the clinician puts in the correct clinical information, because that could be a problem with the software. That said, I think, the things I read for an MS center for an entire year, and it's a nightmare looking at disease burden when nothing is lighting up. Is that a new lesion? Are there two new lesions, or is that just a plain? And
you mean lighting up with contrast, Sylvie?
No, on diffusion, sorry.
Okay.
So I think there's real value in that, and I would defer to the program because volume counting is beyond my capability. I think continued recognition of something emergent is what we all look for, not just on CT, but on MRI. And I also think shortening protocols is a key to the future, because we are just dying under the burden of increased MR, and we want the best people to read the exams. We don't want the neuro exams to go to generalists. We want them to go to neuroradiologists. And I'm sure Dr. Hills agrees.
Thanks, Sylvie. I'll actually build upon one of the first things that you said, which is you need the clinicians to enter the right information. And I'll say, and this is putting on the neurology hat, the thing that I would love to see is actually an automated tool that reads through my clinic note, actually to go one better, one that actually writes my clinic note to begin with as well, but then uses my clinic note to then populate all of the information for the MRI results in auto protocoling, et cetera, and then ultimately interprets the MRI down the path. But something that can actually extract that information and save me from entering a lot of information that, to be honest, is repetitive, it's algorithmic, and it could very much be done by an automated tool.
Yes.
But it's something that in this day and age, I'm still needing to enter myself every time I do order an MRI.
Okay, thank you, James.
I have a comment. If Michelle doesn't want to say something, I have a comment here. I opened the presentation with the spectrum of the healthcare enterprise, the full breadth. And one of the things that large language models are already doing, well, I'm not sure how many commercial products are really out there, is reading the medical record, right? I mean, this is the great value. I almost giggled when I heard Sylvie saying, expect the clinicians give you the proper information because,
They don't.
well, yeah, but frankly, I think
Sorry.
assuming that the medical record has integrity, we should have the ability to scrape that medical record and pull all the relevant information out, as well as any omics that might give us a sense of patient risk and clinical concerns. This is a process that, in the best circumstances today, with the best systems, takes a few minutes of your time to go ahead and look at the what am I looking for? The health record, the electronic health record. But in all honesty, if we have that ability to read the health record, it can then translate into the scanner where we pick the protocol and tailor it to the examination, come back to us, and so that we can do the pertinent positives and negatives, have to make sure our reports are in line with the clinical concern, and again, just deliver higher value across the board. So I remember, since Sylvie told USC stories, I'll tell a USC story. I remember we had rules. You couldn't get an urgent ultrasound unless you said this in the history. And then magically, every ultrasound had this in the history. So honestly, it would be much better for all of us if indeed we could essentially be part of a better, more integrated part of the clinical team by having ready access to all the critical information we need so that we can deliver value on the examination. And this translates all the way through the performance of actually looking at the exam in line and making those kind of adjustments on the fly that we talked about earlier.
I'd like to clarify something I said with the appropriate clinical information. In large academic centers, and I'm sure Dr. Hills is aware of this, it's generally the lowest person on the totem pole who is told to order an exam, and they know the least about the patient. So when you go back and question them, they can't answer, and they have to go back to their attending. And that's what I meant about appropriate clinical information, because usually if it's attending to attending, there's no issue, but generally it's intern to attending.
Okay, thank you for clarification. So Michelle, you have the last wish.
Yeah, I can just say that I'm pretty sure, I feel confident that, let's say, skilled people are working to make your wish come true, James. And I think this is a fruit that we will see in a few years that is ripe to be picked. What my top wish would, it maybe sounds a little strange, but I would like that our world starts realizing that if you want to deploy a package of AI for radiology, in that package, you should also have a tool that will validate your technology on local data at that imaging institution, on their cohort, a real world, not filtered, not no makeup, no nothing. How does the algorithm perform on my patients? But it gets worse, because you also need for the algorithm to have a sense, and you can share this only with, let's say, the chair of the department, what is the human alternative? And I'm sure everybody here are all top-notch experts at what we do, but we can't all be that. And I think we need also to have, let's say, the algorithm packaged with a validation tool to create that transparency. And I think we will see that there are hospitals out there where, like you said, Sylvie, generalists are doing the neuroradiologist's job, which is not something to be very proud of. I think it's a low-hanging fruit in let's say, AI helping to elucidate the quality and to thereby improve it. And that way we will also know when is the AI solution a better alternative than what we already have. And if you say, okay, we don't have that at our institution, I would challenge you to look at what goes on the night between Saturday and Sunday. What's the skill level there?
Great. Thank you very much, Michel. And thank you all panelists for this panel discussion today. I think we had a really wide a wide array of discussions and topics covered. Generally, I think we heard a very optimistic tone, a lot of hope, a lot of expectations of opportunities in the center, but also very pragmatic and realistic assessments of what is needed for adoption and actual broad value creation. So thank you all again for coming, for sharing your thoughts, for discussing. All the questions that were not covered live were covered in writing. Thank you, Larry, for actually answering a lot of the questions in the chat already. So I think nobody has to go home with questions unanswered, even if we didn't find the time to address them in live. So thank you very much to all the panelists. And next stop is RSNA. So we're very much looking forward to meeting you all. And please come over and chat. I think probably all of the participants here will be at RSNA and will be happy to engage further in this discussion. So thank you very much and have a great day or night wherever you are. Bye-bye.
Bye-bye.